In this session, I'd like to think about the word tachycardia. Pediatricians worry about tachycardia because it is one of the few physical signs that we can get of children that we can actually be quite reliable and objective about. It allows us to think about children in a very broad brush approach, and it allows us to really think about which children we should worry about very quickly. But to do so, we have to have an understanding of what tachycardia is, how we would define it, and how we would think about an approach to tachycardia. And that's what we're going to discuss in this session. And this is what I'd like you to think about after you've watched this video, made some notes, and then gone to your clinical areas to think about how you are seeing people think about children with rapid heart rates. The way I would like to think about this is to start from a question, which is, what is tachycardia? In other words, if I have a heart rate of 150, that is very abnormal for me, but it is entirely normal for a newborn. And therefore, the normal heart rate and range will change as the child gets older. If you haven't already done this, you have to go to the wards, have a look at our Pews charts, and familiarize yourself with the way that the Pews charts are laid out so that you understand the way we think about a normal range for heart rate specific to this talk. You have to be able to assess a child's heart rate, and to do this, you're either going to feel their pulse or listen to their heart and count for at least 30 seconds to work out what their heart rate is. You can confirm this with a SATS monitor or with a cardiac monitor, but you have to have a way of describing that child's heart rate in a way that is helpful and objective. The next thing to do is, if you've got a child who is tachycardic, is to think, well, what are the causes of tachycardia? And the quickest way I know of doing this is to start by asking myself a question: could this be a rhythm problem? In other words, is this like most of the tachycardia I will see, in other words, sinus tachycardia with a normal heart rhythm, or is this a arrhythmia? We don't see children with atrial fibrillation or atrial flutter in common pediatric practice, and fortunately it's incredibly rare for us to see ventricular tachycardias and ventricular arrhythmias in pediatrics. What we will occasionally see is supraventricular tachycardia. You need to know a little bit about SVT and supraventricular tachycardia, and you need to understand that small babies will often tolerate SVT remarkably well. If your heart rate is normally 160 and it's now going along at 220, you may actually tolerate that incredibly well for days or sometimes even weeks before you present to a clinician. And therefore, I would suggest to you that you have to have a robust process to think about tachycardia, which is to ask yourself the question, could this be SVT? Almost certainly the answer is no, it's not going to be SVT, and you don't need an ECG. But certainly if the heart rate is over 200 in any child, I think an ECG should be considered, and I would consider that to be pretty much mandatory in a child with a heart rate of over 200. However, most children we see with tachycardia have got a heart rate that is raised, but in a sinus rhythm. And therefore, we have to have a structured approach to sinus tachycardia. My approach is this. There will be some important causes of sinus tachycardia that can happen to any human being at any point in their lives. Stress, pain, anxiety, fever, fear will all raise your heart rate. And therefore, any child in a strange environment with strangers coming up to them, poking and prodding and asking them questions, who's feeling unwell, who may have a fever, who may be in pain, these are all causes for tachycardia that is completely normal and completely expected. And this makes it hard for us because our job is to try and tease out the serious, important causes of tachycardia, which may coexist with those. The child may be septic, but also in pain because they got a headache, and febrile because they got meningitis. And therefore, we have to tease these out. There will be other rarer causes of tachycardia. that we have to think about. The most common of these would be things like anemia. And then very occasionally we will see children where it's a drug side effect. Most commonly we see tachycardia, and we do actually see this a lot with a relative tachycardia in children on bronchodilators such as salbutamol. Very rarely we'll see children with tachycardia because of a tumor such as neuroblastoma or a Wilms tumor, or a child who's got a thyrotoxicosis. These are very rare. And so for me, the vast majority of children I see who have got a sinus tachycardia, I've got to think about pain, fear, anxiety, fever, and I've got to think about and treat these as I can. I've got to try and be nice to the child and reduce their anxiety and fear and distress. I've got to treat their pain and treat their fever if I think it's causing their tachycardia and making them uncomfortable. But the most common, serious, important cause of tachycardia is going to be the child who is shocked. And their tachycardia is a manifestation of shock. They become tachycardic at the same time as they might develop poor perfusion, low pulse volume, the signs and symptoms that I mentioned in the pale child talk that I gave. It is really important that you have a structured approach to thinking about tachycardia, and that you have a structured approach to thinking about tachycardia for age in children that is appropriate for the age of that child, whether it's a neonate where we're thinking about sepsis or congenital heart problems, or an older child where we might be thinking about intussusception or infection or dehydration or whatever the cause for them being unwell is, that we have a structured approach to this. In this session, I want you to make sure that you've gone and had a look at the Pews charts, and I also want you to make sure that you can think about how to take a blood pressure in a child. This is a skill that is much like taking a blood pressure in adults, except for the fact that you have to have the correct size cuff. You have to do it in a way that allows the child to be as relaxed and as calm as possible. And this generally would mean doing a manual rather than using an electronic SFIG. And then when you get those results, those have to be compared with the normal range. It is important that we do blood pressures in children. It is important that we can interpret them correctly, because hypertension in children is never normal, and hypotension is a very worrying sign, either of impending problems relating to severe uncompensated shock or relating to a child who's becoming increasingly unwell because of poor myocardial function. In summary, you need to make sure that by the end of this attachment, you can appropriately assess an acutely unwell child in terms of their cardiovascular status, and you can think about the differential diagnosis. One of the difficulties with examining the cardiovascular system in children is their heart and heart murmurs, and it is outside of the scope of this short attachment to teach you very much about heart murmurs. However, what we would expect you to be able to do is to listen to a child's heart, to be able to spot if it doesn't sound normal, like if it sounds like there's an extra sound, and then to think about the fact that up to a third of normal healthy children can have a murmur, and therefore this isn't a panic, but we do have to have a think about whether this is a murmur that we need to worry about. And during your attachment, it would be sensible for you to spend a little bit of time talking to somebody about how they think about heart murmurs and some of the features that might reassure them or worry them, and want them to get a more urgent, more expert pediatric or pediatric cardiology review.